you. And this first case that I'm going to talk about, I think is important to address the differences between my two cases. We have hemorrhage carts all over my facility intentionally so that they're easily accessible, but depending on the size of your institution, you may be at a critical care access hospital or a tertiary care center. It really doesn't matter. You should make sure that you're aware of where those hemorrhage carts are, because even the non-suspecting patients can become postpartum hemorrhage patients very quickly. So this patient really wasn't on our radar for bleeding. She was a 31-year-old patient, G1P0 at 39 weeks, and she presented for an elective scheduled cesarean that she had requested. And the one risk factor that she had for postpartum hemorrhage was her morbid obesity, but she wasn't quite like, the risks that Dr. LaFleur just listed for her patient. And so our spidey senses were not quite as heightened for this patient, but it's important that we knew how to manage her when she did develop that. So she was taken back to the operating room for her scheduled section. She was consented by both anesthesia and the surgeon themselves, and she had spinal anesthesia was administered for her primary C-section without complication. And she had a uncomplicated primary low transverse C-section without any issues. And in fact, her entire case itself was running just fine. So she had a delivery, had normal IV Pitocin running through her IV fluids at that time. And then the case had been completed. So her hysterotomy was closed, as well as her abdominal incision. And then when the drape was pulled back to begin and continue to clean her up, and then fundal massage was started, it was noted that she was having more breath bleeding and abnormal uterine bleeding that was related to atony at that time. So they began doing an assessment. I was asked to come in the room, and I was helping assess and evaluate as well. And she was given, in addition to the IV Pitocin that was running per protocol, she was given 800 mics of oral Cytotec to help with her uterine atony. And we were doing bimanual massage, and she was a scheduled section. So she was about 2 centimeters or so prior to the C-section. And just as Dr. LaFleur mentioned, the manipulation and attempts to sweep the uterus to really get those clots out of her uterus had dilated her to like 3 or 4 centimeters by the time that was all said and done. So we were noting the abnormal bleeding, and she was given that Cytotec, and then she was also given an additional dose of a uterotonic, which was the Metrogen. So she got 0.2 milligrams IM given during this evaluation as well. In addition to that, she was given an antifibrinolytic. She was given 1 gram through her IV. And so she had 4 uterotonics or 4 medicines at that point, and then it was decided to perform QBL while that evaluation was happening. And it was noted that she had 2,108 cc of blood loss, inclusive of the OR time plus the active bleeding that was happening at that moment. And that's when the JADA was requested. So our postpartum hemorrhage cart was brought in, and she was typed and crossed for 2 units of blood to be held, and the JADA was inserted. The JADA was inserted similarly to the way that Dr. LaFleur just described. Our patient remained on the OR table. She was frog-legged, and I was able to place the device without any issue. We used the suction device that we have in the OR for normal suction, making sure that we change that to 80 millimeters of mercury, and that's something that we have trained several times with our simulations to make sure that we decrease that suction level from its normal in case suction level. And it was decided at that time during the insertion that she was going to receive 1 unit of packed red blood cells as well. So she had some labs that were drawn and sent, and that first unit of blood was ready, and the JADA was inserted without any difficulty. I also placed 120 cc's of sterile fluid in that cervical seal without doing 60. In my experience, I have always eventually ended up increasing that, and so I just always placed 120. And part of our simulation is to make sure that 2 50 cc syringes are filled with that sterile fluid on that Mayo tray or Mayo stand or our delivery tray. So when I ask for the data, they already insert that for me. And her bleeding was controlled within 3 minutes. So we were still in the operating room. We were able to quickly see that she had sort of a pretty large gush initially with placement and started of the suction itself. And then we had another 175 cc's of QBL after placement of the device. So her bleeding was controlled within the 3 minutes. We hung out in the OR for about 10 or 15 minutes watching and making sure that we were stabilizing and not having any further concern. And we were able to continue to kind of clean her up and prep her and get her ready for transportation to her postpartum room. So she was taken to her recovery room, and in my facility, that is in a postpartum room where, well, it used to be, it's not anymore now, we have a new facility, but it was at this time in our postpartum room, and she was taken to the postpartum room in recovery. And we left that JADA device in for a total of 6 hours, which was inclusive of that 30 minutes of observation time. And that's one point I want to make out. We have not continued to use the device as long as we did initially. So this was an initial case of mine that we had within the first few months of using JADA at my facility, and we've gotten a lot more comfortable with how quickly it works and how efficient it is. And so the 6 hour indwelling time was kind of our first couple of cases. So she had a total QBL of 2,283 cc's, inclusive of the operative time and then her postpartum hemorrhage afterward. And so to summarize this timeline, I was able to really quickly control this patient's bleeding, even though she was not really high on our radar for postpartum hemorrhage due to atony. And we had the postpartum hemorrhage cart outside of our OR. And once we determined this was atony and we knew that we needed it, I was able to place it really quickly. I was able to control her bleeding with the JADA device within 3 minutes. And I was able to get her up and walking pretty quickly afterward once I was able to remove this device. She didn't have any additional uterotonics that we used besides the IV Pitocin that was running through protocol, and she received that 1 unit of packed red blood cells in the OR during that procedure itself when I had placed it, and she didn't receive any additional packed red blood cells or any additional units after that.